Today, I would like to present TAVR thrombosis. I think everyone is quite familiar with the definition of the halt, the RLM, reduced leaflet motion, or the HAM. The HAM is like a combination between halt that's caused the reduced leaflet motion. The valve thrombosis right now is defined as one type of the bioprosthetic valve dysfunctions. This is not the structural or the non-structural valve dysfunction. And the valve thrombosis was classified into the subclinical and the clinical significant. However, the definition of the clinical significant from the last three is quite complicated and confused. The pathophysiology of the thrombosis of the valves is multifactorial. Sometimes it may be come from the systemic factor themselves. The patients may have the hypercoagulable state like obesity or something, and some patient factor can have the effect on the flow, like impaired left ventricular function or the low flow, low gradient aortic stenosis. And also, if the patient doesn't take oral anticoagulations, there is a risk of the thrombosis too. The second is maybe the flow dynamic. The intra-annular design TAVR have a higher thrombosis more than the supra-annular designs. The deployment depth, the commercial alignment, coronary washout, valve in valve, the paravalvular leakage less than miles. So sometimes we still don't know the real reason of the thrombosis. Like the TAVR valve is too big or too small. There's large sinus of the valve, the small neo-sinus. And for the serpent 3, if you overexpand or if there is some location with the underexpansion, it can cause the thrombosis too. The thrombosis of the valve is a dynamic process. Sometimes it can spontaneously reverse, but sometimes even more than 3 years, the valves still can have a chance of thrombose. Look at this data. Choice of the valve also have the effect on the valve thrombosis. The balloon expandable valve have a higher rate of the valve thrombosis than the expandable valve. This phenomenon can be explained by the size of the sinus and the neo-sinus flow dynamic. The self-expanding supraannular valve seem to have a faster washouts compared with the equivalent size balloon expandable valve. And the implantation technique between the different kinds of the valve also have the different impact factor on the valve thrombosis. From this paper that studied about the fluid mechanics of the TAVR valve, it had a factor influence on the leaflet thrombosis. You can see that if you use the SAPIEN 3, if you expand the valve 10% further, you can increase the risk of the thrombosis. For the core valve and the evolute R, it is not depend on the expansions, but it's mainly depend on the implantation depth. And from the in vitro study, the supraannular size has a 7-fold decrease in the stagnation zone size, and the stagnation zone increase as the crack output decrease. Not just only about the expansion or the implantation depth, but it's also about the TAVR deformity. From this study, they studied about the deformation of the valve and the occurrence of the halt. If the valve have the greater prosthesis frame deformation, the worse asymmetry of the leaflets, the smaller TAVR neo-sinus volume. All of this is a factor of the halt formation. The washout effect is also the one of the important protective factor. This is the study from the Basilica trial. All of the halt occur in the non-coronary leaflet, and no halt was seen on the leaflets splitted by the Basilica. Another problem of the halt is that is there any clinical relevant? If you look at this data, the clinical halt occurred only 0.6 to 2.8%, but most of the case is a subclinical halt, it is 4 to 40%. And also the clinical significance, some clinical like a TIA or stroke is also confounded by the common risk factors predisposing to both the stroke and the leaflet thrombosis. And sometimes for the subclinical halt may be progressed in the severity and become to have a symptom later. And the thrombosis itself can be the nidus for the structural wall dysfunction in the future. This process can be modifiable with the oral anticoagulation, and it also have a dynamic in time and a heterogeneity in time. As shown in this chart, it is an unclear clinical impacts about the halt. You can see that if we divide with the CVA or stroke and the increase of the gradient, the pneumonic valve dysfunction, some data set show you that there is increase both CVA risk and also increase the gradient. But some increase only the stroke, some increase only the gradient, but some not both. Even if there are wide varieties of the definition of the complication like CVA or TIA or the flank stroke, the gradient is depend on time, immediate 30 days or 1 year. And this is an example of the studies that demonstrate the dynamic process and the heterogeneity in time of the incident of the halt. One is from the Evolute low-risk sub-study. You can see that the halt occurred at the 30 days 26 patients, but after 1 year, the halt is only 15 and 11 cases there is no halt at all, and only 2 patients that have oral anticoagulation. However, in the opposite way, if there is no halt at 30 days, and in the end, the patient can have a halt, and all of them didn't take any oral anticoagulation. This data is also confirmed by the partner 3 sub-study. At the 30 day, the halt occurred in 25 cases, but after 1 year, there is only 44% that still have a halt, and 56% there is no halt at all. About the clinical relevance, this data show that the halt incidence is 6%. However, the halt can increase the stroke risk. The risk ratio is 2.54, and the oral anticoagulation can resolve the halt 99%. Vice versa, there is some studies that show that the halt has no clinical relevance. For example, these 2 studies come from Japan. First study using the ocean registry data, and they perform the CT scan of the TAVR without any oral anticoagulation in all patients. The halts occurred 9.3%. Most of the case is the balloon expandable valve. For the supraannular design expandable valve, the incidence is only 8.9%. The gradient occur only at discharge, but not later. And the halt can occur late as up to 3 years, and the endpoint, the primary endpoint such as death, stroke, rehospitalizations is not increased. Another study, they include only the SAPIEN XT and without any oral anticoagulation again, and perform the CT at 6 months and 1 year. The halt incidence at 1 year was 21.8%, and also there is no statistical significance in the endpoint. There is some trials that try to prevent the halt by using the oral anticoagulations after the TAVR. I think everyone knows these 2 studies quite well, the Galileo and the Atlantis, so I won't give into the detail. However, the conclusion is that The halt and the reduced leaflet motions is not implied that it will increase the stroke, thromboembolism, or death. And the oral anticoagulation can reduce the halt and the RLM. But the oral anticoagulation might cause harm about the breathing more than the benefit of preventing the halt. However, both of the randomized control trial studies is performed in the patient that's quite old and a high risk. How about the data in the low risk group? This study is performed by using the oral anticoagulations in the low risk, and it showed that at the 30-day outcomes, the TAN catheter heart valve dysfunction was reduced significantly, 7% versus 26.5%. And also the major and the life-threatening bleeding that's not increased, even is mild increase, but there is no statistical significance. And is the thrombosis is the nidus or the predisposing factor that increase the rate of the structural valve dysfunction or not? Right now, we still don't know because the long-term outcome of the TAVR is still not established yet. But if you look at the data from the TAVR, from the surgical valve, there is one study from the Mayo Clinic that using the echo to diagnose the potential of the thrombosis of the surgical valve. They can identify 83 cases, and then after that they give the oral anticoagulation to the patient. The 21 cases is non-responder. However, there is a responder 62 cases, but there is the incident of the rethrombosis in 14 cases. And if you look at the long term, the probability of the redo valve replacement, even there is a responder group, the incidence of the redo replacement is higher than the group that without. By conclusion of this study, the valve thrombosis was associated with the rethrombosis and the early structural valve deterioration. And indefinite warfarin anticoagulation should be considered in the patient that have the history of the halt. However, you have to balance between the breathing risk. There is one set of the unanswered questions that's proposed in JAMA in 2022. So I will answer one by one, but I think I cannot completely answer all the questions. First, do we need to screening for the halt? From the data right now, there is no clinical impact about the halt. So currently, no, we don't need to do the CT scan in every cases. However, we have to wait for the long-term low risk group outcomes that the halt can increase the structural valve deterioration or something. The second question is about oral anticoagulation in the high risk group. For example, in the valve-in-valve group, as everyone knows that after the valve-in-valve, the benefit of the valve-in-valve was lost when compared with the redo surgical AVR after 1 year. Right now, we still cannot completely explain. The halt may be one of that factor. Yes, I think the oral anticoagulation maybe have a clinical benefit in the patient with high risk of thrombosis, but not high risk for bleeding for sure. And if we perform the valve-in-valve, should we do the basilica in every case? I think we cannot answer it yet. And the third question is that the relationship between the leaflet thrombosis and the future structural valve degeneration or not. Right now, from the surgical AVR data, I think it's possible, and from the histopathology, it's also confirmed that. However, for the TAVR, currently right now we don't know. As long as 3 to 5 years, there is no effect about the halt that can increase the gradient. We have to wait like more than 10 years data. The fourth question, does the treatment of the leaflet thrombosis with oral anticoagulation reduce the risk of the structural valve degeneration, thromboembolism, or the stroke? Right now, it is unclear clinical impact. However, if we look at the fifth questions about the low dose oral anticoagulation, I also consider to use the low-dose anticoagulation in the low bleeding risk. Right now, it was classified as the class 2B in the ACC and AHA guideline. The sixth question: if there's a halt, clinical significant halt, and we need to use the oral anticoagulation, how long? We have to use the oral anticoagulation at least until the halt was resolved, or even lifelong if we trust on the data of the surgical AVR. The last question: how does the valve choice and implantation technique influence the risk of the leaflet? Different THV have a different incidence of the halt, and different implantation techniques between the THV also have impact differently between the valve choice. What is the current clinical approach? According to current data that we have, this guideline is reasonable. If the patient have a clinical, if we confirm by the CT scan, the patient should be admitted and give the IV heparinization if there is acute embolism, and then we treat it with the oral anticoagulation for 3 to 6 months. And after that, we repeat the CT scan. If the halt is resolved, you have to check with the bleeding risk. If there is the benefit more than the bleeding risk, I think we should continue the oral anticoagulation. But if there is a persisting of the halt or the ILM, we have to continue with warfarin. For the asymptomatic patient with only increase in the gradient, if we confirm with the CT scan, we start with the oral anticoagulation and then repeat the CT scan in the same protocol with the symptomatic halt. And that's all about the evidence review about the halt. Thank you for your attention.